PSA density as well. Those are important markers. And now MRI is available everywhere. The quality is maybe questionable, but at least if you get familiar with reading the MRIs, you may be able to, avoid more frequent biopsies.
Sir, I am coming from Dhaka. My name is Dr. Salam.
Yes, sir.
So, it is very difficult to convince the government to spend money on national screening program.
Right.
So, do you consider that the social media can be a very useful tool for awareness program?
Absolutely, sir. Especially for education.
If it is being done, if you agree, or if the panel agrees, then it may be a good procedure because the patient will take the burden of the cost.
Right.
And thereby whole responsibility goes to the patient and the clinician.
Right,
so
sir.
Nationwide it can be a good solution.
Thank you, sir.
Dr. Vivek,
one last question, sir.
Comment, not the question.
Okay.
See, when we see the population-based cancer registry data for the prostate cancer from all over India, south, north, southeast, the major obstacle is treatment completion. 40% drop out of the patients. So first thing, what is available to see that as a treating consultant, the patient should complete the treatment. The population-based cancer registry survival is showing just 25% to 30%. So all the treating consultants see that patient should complete the treatment. What is available base should be provided. And there are government schemes. We need to raise the awareness of the prostate cancer as well as the awareness about the government schemes available for the treatment completion.
Thank you.
Thank you.
Thank you, Dr. Vivek Venkatramani. I now invite the next speaker, Dr. Ananthakrishnan Shivaraman. He talk on prostate biopsy, logistics and tips for transition to transperineal biopsy. Dr. Ananthakrishnan is Director of Robotic Surgery, Uro-Oncology, Chennai Urology and Robotics Institute, Chennai. Over to you, sir.
Good morning. I must thank the organizers, Sogocon and TMH. It's always a pleasure to come to TMH, where we're among friends. So before I start, how many of us are doing transperineal biopsies in this auditorium? Hands up. So just a small sprinkling, but anyway, so then that makes this talk all the more useful. So we've been doing transperineal from 2019 onwards, and there are very valid reasons to shift over to transperineal biopsy, right? And the key among them is lack of infections. You do not get infections when you're doing transperineal, very minimal infections. The last 4 years, we've not had a single patient that needed admission after transperineal biopsy for an infection cause. Now, we've all been doing transrectal biopsies all along, and you've had this one patient at least once a year. You need to take him to ICU, significant infections, and so on, right? So that doesn't happen in transperineal biopsies. And out of all the points listed here, the other important entity here is you're able to target the apical zones of the prostate better when you're doing transperineal biopsies. So I think these two advantages alone should make us as a country move towards transperineal biopsies. And the rest of the pros and cons listed here are pretty useful as well. So, right, this is European Guidelines 2023. Now, as you say, the writing is on the wall. Transperineal biopsy is now first choice, right? Straight away. It is first choice. And in this day and age, when we counsel a patient, what is the state of the art? The first choice here is the state of the art. Right? We can't effectively tell them that we'll clean the rectum, preoperative prophylactic antibiotics, and so on, right? When you have a better choice in front of us. So we really need to move to transperineal biopsies. And my job here is to convince you to move to transperineal biopsies, right? So I'm not talking about this sort of biopsy, right? The picture on the, do we have a point? Yeah. So not this one here, right? This is what radiation oncologists use for brachytherapy. And you need a stepper for this, you need an attachment, you need a whole lot of equipment that's pretty expensive. We're talking about freehand transperineal biopsy. And that doesn't need any equipment. If you're already having a biplane probe in your hospital, you can straight away go ahead and do a freehand transperineal biopsy. So you don't need extra equipment, right? I'll elaborate a bit more on this. So you definitely need an ultrasound machine, right? So the next one is you need a biplane probe. And 99% of hospitals in India would have a monoplane probe, which is a transvaginal probe, which a lot of us used to use for transrectal biopsies, right? Now, that's the first step. That's a brilliant step. That's better than getting the radiologist to do the biopsies, right? If you're not doing biopsies at all, that's an excellent equipment to use to do transrectal biopsies. Unless you gain that experience, see how the prostate looks on the ultrasound, you really won't be able to do a transperineal biopsy. That's number one. Number two is you need something called a stabilizer, and as your experience increases, you can do away with that stabilizer. And most important out of the lot is you need a mindset change. Unless you do that, if you change your mindset that we really need to start transperineal from now, it's not going to happen. So probe, I'm going to show you the probes that we need. So this is BK, right? Most urology departments vote for BK when they're buying transrectal biopsy or ultrasound machines. That comes with an attachment that is, it comes with an attachment to allow you to do transperineal biopsies, right? And this is the CAM probe. This is used in Cambridge. It's nothing but a coaxial needle, right? All you need to do is see the entire track of the needle from the skin to the prostate. Now, all of us, or most of us here, have come from a urological background, and then we've all done PCNLs, right? From skin to calyx, it's about 10 centimeters. From skin to prostate is less than 4 centimeters. Can we not do that? Absolutely, right? It's not such a big deal. Right, so this is what we are using. Now I put two entities here. So if you see, this is the stabilizer that we're talking about. It's called precision point. And this is the transrectal attachment that I put here as well. So you see the difference between this entity and that entity is the needle is slightly away from where the linear array is. So you need this sort of an array. So this is the transverse array, ultrasound. This is the sagittal array. So the needle just stops just in front of the transverse. So this is the distance that you need to traverse before you see the needle. And it's not that difficult at all. Right? Once you start using it, I'm going to show you a couple of pictures. So when you use the transrectal entity, the needle comes just in front of the transverse array. When you use the transperineal, slightly different. Yeah, you can even push it forward, it will impinge on the skin, so slightly uncomfortable for the patient. So this is a locally made stabilizer that mimics the precision point. Now that's going to be available in India, so that shouldn't be a limitation for us moving to transperineal biopsies, right? This is the precision point, 3D printed copy, and this is an autoclavable entity as well, right? So again, the stabilizer is never the limiting point. I've usually found that it's a mindset and a biplane probe. So all of the machines have a monoplane probe. The biplane probe is somewhere around 5 to 6 lakhs. If you invest in that, I think it's reasonable, and we can go ahead and do the transperineal biopsies. Now, the other important thing that I'd like to emphasize is all of the machines, not just BK, not just Hitachi, all of the machines available in the Indian market now do come with a biplane probe. There is no machine that I've looked at in most of the hospitals. This is GE, that's Mindray, that's SOT. All of them have biplane probes. So just look at the machine in your hospital. I'm quite certain it comes with a biplane probe, right? So just to enthuse you into getting into looking at it. Most of the departments are happy letting the radiologists do it. I think that's a bigger battle for urologists now, that we need to get into transperineal rather than allow the radiologists to do it, right? So this is key. So this is what I mean by checking the alignment when you do a transperineal biopsy. Unless you see the entire tract of the needle in the sagittal plane, you will not be able to direct the biopsy gun to the area that you need. So just check before you start the biopsy. So this is just how we check. Right? Before you start the biopsy, just put it in a bowl of water and then make sure you see the entire tract of the needle before you start doing it. Right? You see it both in the sagittal plane and in the transverse plane, and that's essential as well. Transverse tells you left and right, sagittal tells you anterior, mid and posterior. Right? So local infiltration, this is what we do. It's just standard local, be liberal with local. Even if you're doing transrectal biopsies, mandatory to have local. Right? I'm going to quickly go on and then show you what we mean by this is one of the fundamental differences between transperineal and transrectal, right? It's not apex, mid-gland, and base. It's rather anterior, mid-zone, and posterior. So this is how you stratify your biopsies when you do transperineal biopsies, but you target more or less the same areas. You just call them differently, right? And another advantage is all of the biopsies go through the anterior zone, that is the peripheral zone of the prostate. It's impossible to make a mistake without hitting the peripheral zone. Now, before you do a biopsy, mandatory to have an MRI. Don't do biopsies now without an MRI, multi-parametric MRI, and your radiologist, or you should not, we should all start being good at reading MRIs. We should have a mark like this before we start doing the biopsies. Now, do we need any specific fusion software? And two RCTs have come and review articles, again, systematic analysis, meta-analysis, have shown that there is no difference between transperineal, transrectal, transperineal, cognitive versus fusion versus software fusion or in-bore biopsies. I'm going to quickly show you a couple of videos of how we do the biopsies before we start taking questions. So here, the key is the needle, the biopsy core. You will be able to target, but you should be able to see the biopsy core in every section of the prostate before you hit the prostate, and exactly where you need to take the biopsies as well. Now, if you're taking cores from the base of the prostate, you need to travel a bit into the prostate and then start firing the gun. Again, there you go. This is right base. You'll see me travel right into the prostate and then fire the gun, right? It's more or less straightforward. Once we get the hang of things, you will never look back and not go back to transrectal biopsies. Now, quickly just show you the last one, how we do an anterior aspect of this prostate. Now you see me target the anterior aspect of the prostate. Again, this is also peripheral zone, right? It's not anterior fibromuscular stroma. Though we're medial aspect, it's still targeting the peripheral zone here. And one final, right? This is the right lateral. So you see the transverse here gives us whether we are left or right, and this shows us how close to the posterior aspect of the prostate we are. So I will direct you to look at this paper that came out from our unit, feasibility of, it's got most of what you need to transition from transrectal to transperineal. And we've been doing it for the last 4 years. Trust me, this is the way forward, and I hope all of you change. As a country, India needs to go to transperineal biopsies. Thank you.
We have 4 minutes for questions.
Anant, excellent discussion and presentation. Actually, last 2 years we are completely shifted to transperineal, and we can now vouch the advantage of transperineal. And our fellows are also trained entirely in that. Our problems, few points I wanted to highlight is because you have got a precision equipment which is not available in India and it is not freely available in the market. What we have is BK has got an attachment, a bit costly, but issue with the attachment is that has got multiple holes and we have to puncture at different areas. And naturally, the patients are not happy without an anesthesia, so we are forced to go for anesthesia. So I was discussing with them, then they were telling that as you do with a BART needle, we can just adjust without using the stepper. So probably what we can do is initially we may have to do a stepper, and probably if you are doing away with the stepper, the anesthesia factor can be avoided.
It's straightforward in the sense there's only one single puncture in the perineum on the left or the right. So and one single puncture is enough because the skin there is so pliable. So all you need is put the needle in the skin and then push it up or down and get right into the area where you want it to the prostate. So there are no multiple punctures as well.
But in the BK,
even in the BK machine, what you can do is have this needle separate. Don't allow it to come through the through the attachment. Just the probe comes through the attachment and the needle is in the perineum. So just that part of it where you hold the needle and then allow the biopsy core to go into this needle, coaxial technique, that's enough. I would suggest you try that.
And you showed the auto-capable precision thing. Is
Yes.
it made by your team or is it available in the market?
Most of the manufacturing of this entity is done in Gujarat, I think. So
Okay.
one of the manufacturers there is doing it. So I'm happy to share his
Please share
details.
it.
Yeah. So all of these guys have literally visited 10 to 15 people, and they don't see the value of doing one single entity. The process that goes through with it, and probably how many autoclavable biopsy stabilizers is the entire urology community going to buy. So it's not, there's no effort reward ratio in them for the manufacturers. Unless it's a disposable one and you use it for every case that you do. So they're a bit averse to manufacturing something like that.
So for everybody's information, we are conducting a dedicated course in October on transperineal and other biopsy methods. And Anand also is coming as a faculty in that. We are having everything as a workshop.
So there are 3.
Pardon, sir? No, actually we are planning to have the BK system.
So there are 3
One
types
last
of fusion
question
available.
now,
One
please.
is the software fusion, other is the en-bore biopsy, and the final is the cognitive fusion. Is there a difference in the cancer detection rate? Not much, not statistically significant difference, right? So in a country where people are not doing biopsies, urologists, to asking them to get fusion is a big step forward. My suggestion would be to first start doing the biopsies, MRI cognitive biopsies, then look at the next level.
Anand, can I ask you a question?
Sure, Amit sir.
So we are running out of time, so please be quick.
One quick question. I think a very well appreciated presentation. There is no debate around that this is a good form of biopsy. But does it actually, on the premise that you said, that there is on the grounds of infection and position of the tumor, you have selected and recommended transperineal. I disagree with the first